My name is James Orbinski. I'm the principal here at Massey College. And welcome to Health, Science, and the Democratic Trust. This is a conversation that speaks directly to the moment that we are living through. Let me just first acknowledge that we are on the treaty lands of the Mississaugas of the Credit First Nation and the traditional territory of many nations, including the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and that this land is also home to many other Indigenous people, First Nation, Inuit, and Métis, from across the country, or what many, especially our Indigenous brothers and sisters, refer to as Turtle Island. We're very grateful for the opportunity to work on this land, and we very much recognize that it's our collective duty to share and care for this land. And with that, again, let me welcome you to our Massey Dialogue on Health, Science, and the Democratic Trust. This is a conversation, as I said a moment ago, that really speaks to some of the core currents of our time, core political currents of our time. Across Canada and around the world, trust in institutions, be they scientific, medical, democratic, or of any formal public institutional nature, this trust is being tested. And how we respond to these challenges will shape not only our health systems, but also the vitality of our civic life itself. Now, this event has been organized by Junior Fellows Catherine Stratton and Ferdinand Reke Avikpe, which I hope I got right. Oh, is that pretty good? Okay, excellent. Yeah. And their leadership really does exemplify what makes Massey College so special. Our junior fellows are not only outstanding scholars, they are also conveners of dialogue, builders of community, and leaders in thinking about the public good. Catherine's work on rare disease registries and patient engagement, and Reke's research in biomedical engineering and stem cell modeling remind us that the future of medicine depends as much on collaboration and commitment to the public good as it does on technical innovation. Now, please join me in thanking them, as you already have done, but let's do it again, for bringing this conversation to Massey. Here at the college, we convene conversations that help our community and our country understand itself in a changing world. We try to bring scholars, practitioners, and students together to wrestle with some of the difficult questions of our time, and to do so with clarity and with purpose. And this afternoon's discussion continues that commitment. We have some wonderful panelists who've joined us. First, to my far left, is Timothy Snyder, who is a senior fellow here at Massey College, and is professor and chair in modern European history, and that chair is supported by the Temerty Endowment for Ukrainian Studies. He's also at the Munk School of Global Affairs and Public Policy. He's one of the world's leading thinkers on democracy, and I would argue one of the 21st century's most prominent public intellectuals globally. He's one of the world's leading thinkers on democracy, on authoritarianism, and on freedom. And his books, including On Tyranny, and one of his not so well-known books, but very important books, Our Malady. His books remind us that access to healthcare is not simply a technical question, but a democratic one. We're also pleased to welcome Mamatha Bhat here in the middle. Oh, sorry, at the far right. There you go. I always have to do that. Even at this age, I have to, which is my left, which is my... Anyway.
James, just if you'd say either one. Thank you. You're always right.
You see, this is why we are so grateful to have Tim with us. Such wisdom. It just drips from him. It's amazing. Please take a bow. Mamatha Bhat is a hepatologist and a clinician scientist at the University Health Network. And she's also associate professor of medicine at the University of Toronto. Her work uses artificial intelligence and precision medicine to improve outcomes in liver transplantation. And while her leadership, in clinician scientist training and AI in medicine speaks to the future of healthcare innovation in the country. And then finally, somewhere in the middle, we have Dominik Nowak, who's a family physician and department head of family and community medicine at Women's College Hospital. And he's also former president of the Ontario Medical Association. And Dr. Nowak has been a leading voice in strengthening Canada's health system and rebuilding trust across institutions that Canada depends on. So together our panelists will explore how access to care, technological innovation, health policy, and democratic values, how do these intersect? And how trust, or a lack thereof, can be strengthened or weakened in this, what I would call a dialogic process between those four kind of core elements. Our panelists will help us consider Canada's role in positioning health and science not only as a national priority, but as a central activity of contemporary liberal democracy. Thank you all for being here. I'm very much looking forward to the discussion, and please join me in welcoming our speakers to Massey College. Over to you. Take care.
Okay, welcome again, and thank you all for being here. I'm so excited to dive into the discussion. To start us off, we'd like to ask each of you about your work or your field. Where do you see democratic norms or trust in science most tested? Now, I'd like to start with Dr. Snyder, especially given your work on democracy and fascism, especially in the Eastern European context.
Okay, I'm very happy to try to set the stage. So I should make clear, as I think James has made clear, that I'm not here as a physician or a medical researcher. My only qualification in this sort of conversation is to have been a patient, essentially. But I will say that that's actually a useful point of view, and it's where I'll be coming from. But professionally, I'm a historian, and it's a good question because if you take a big enough loop, the things that trouble me in my professional life do connect with the things that troubled me as a patient. So, as a historian of Eastern Europe, naturally, I am a historian of propaganda, disinformation. I wrote a couple of big books about totalitarianism, in which one of the most important elements is the way that coherent narratives can replace the small facts. So that one way of going through life is for things to make sense to you, even if the things that are making sense to you do not actually correspond to any kind of external reality. In other words, it's a basic finding of the history of the 20th century that it's possible to live your life in what we call now alternative realities. You can live a life that's coherent and makes sense to you without a lot of the things that you believe to be true having much of a correspondence to external reality. So in my world, then, as we move in towards the present, that's relevant to things that I care about, like the Russo-Ukrainian war, where Russia, in the early parts of the second decade of this century, was very far ahead of others in operationalizing or weaponizing certain kinds of vulnerabilities. The Russians were very quick out of the gate to understand that the way social media worked was to hover around the things that we want to believe, or hover around the things that inspire us to stay online, and to use that vulnerability or to use that set of temptations to get people to think certain things about a war. And so their accomplishment in 2014 when they invaded Ukraine was essentially to do so without people calling it invading Ukraine. If you can remember back 12 years ago, a country was invaded without anyone ever really quite saying that a country was invaded. And so that got me thinking about the way that got me thinking about a process which began in Russia and was spreading through Europe and in North America into my country, and was associated with Brexit and with the election of Donald Trump, I think, which is a broad shift, which is sadly aided by what we call technology, away from a kind of fact-based, or at least tenuously fact-based experience of life, towards a more coherence-based experience of life, where your own personal coherence is aided, or is goaded, you're seduced into a kind of coherence that seems best for you, but which may in fact leave you vulnerable. It may leave you mistaken on major issues of life. And so without saying much more, you can see how that connects to the question of health. I mean, there's an obvious direct connection, which is that the Russian Federation does in fact engage in Canada and the United States in quite considerable disinformation operations having to do with vaccination and other health issues. That's the kind of easy connection to make. But the broader connection to make is that as we move into this world in which there's a kind of manufacture of personal coherence for everybody, we are, by way of what we call technology, we are drawn away often from what is evidently good for our bodies, and indeed drawn away from thinking of our bodies as an essential part of ourselves, where our personal coherences are essentially psychological, they're essentially mental, and they take place between us and a screen. And so we're led away from thinking about our bodies at all. Just one little footnote before I stop, which is that I've been trying to remind myself to say what we call technology, because I think that word is often abused, and I'm just going to give my little definition of it so you know what I mean. I think it's only technology if it's enabling. If it's disabling, it's not technology. And so a lot of things that we call technology, I think when we use the word technology for them, we're actually just repeating the propaganda of the people who make profit from them. So I think that's thinking of technology as only being what is enabling can be a good start maybe in this sort of discussion.
Thank you so much, Dr. Snyder.
Dominik Nowak, I'm a family doctor, and who here has a family doctor? So the majority of this room, that's good to hear. And it's not representative of the majority it is representative of most of Canada, but too many people can't find one, right? And what I'll say as a family doctor is I care for people from newborn babies all the way to, some of my patients are in their 90s and thriving, all the way to, up until recently, I was still doing home visits. So caring for people in their last few months or weeks or days of life. And it's really special to be a family doctor. In my leadership hats, I'm also an optimist. And for me, optimism means realism and hope. And if I were going to ask you, just be real for a moment around where Canadian healthcare is, what's one word that you describe as the vibe check of Canadian healthcare right now? Just throw out some words.
Stasis.
Stasis? Yeah, what else?
Crisis.
Crisis? Who said crisis? Raise your hand. Yeah, crisis. What else? Give me a few.
Necessary.
Necessary. That's a good one. Love it. One in the back. Fractured. Let's get one or two more.
Blessing.
A blessing. Yeah, beautiful. Another optimist over here. Needs improvement. And overwhelmingly, when you ask people about our healthcare system, and we get these words like crisis, catastrophe, strained from health professionals, moral despair because their patients can't get through the waits, can't get the care that they need. Something like 1 in 4 people can't find a family doctor. Last year, emergency departments closed. I think more than ever, the emergency department closures because of physician shortages and nursing shortages, and we have a workforce that's under pressure. Right, so that's the reality of our healthcare system. And when you think about people reaching out to public institutions, healthcare is a main one. People experience how government delivers, how our country delivers, based on how they interact with the healthcare system. On the other hand, optimism also means hope. And Canadian healthcare, if you look at Canada, we have world-class doctors, world-class hospitals. We have world-class science as well, world-class outcomes. At Women's College, which is my site, We're expanding access to primary care. We're launching an AI living lab to look at how AI can actually be productive and help our workforce rather than hinder our workforce, and how technology supports the care rather than hinders it. And then also, we're looking at what do teams in healthcare look like, and how do we spread good teamwork across the healthcare system. So healthcare is such a beautiful example of a public institution that we can nourish, cherish, and support to restore and build trust in generally Canada and a better Canada for the future. And that's our premise, I think, for this conversation today.
Okay. Hello, everyone. So my name is Mamatha Bhat, and I'm a clinician scientist and transplant hepatologist at Toronto General Hospital. We have the largest transplant program in Canada, and as a practitioner who evaluates, takes care of patients along their journey towards a transplant. So I take care of patients, I evaluate patients with end-stage liver disease, liver cancer, for liver transplantation. I take care of them during the process of the surgery, surgical admission, and then post-transplant. And in a way, I end up being the family doctor for these patients during their second life. So it's a great opportunity and really wonderful to see the transformative effect that transplantation has on our patients. And in fact, I look after patients for several years post-transplant, optimizing their health post-transplant so they can lead successful lives thereafter. So as a clinician scientist, I spend 25% of my time, technically, 25% of my time doing clinical work, and 75% of my time doing research. And I lead a highly interdisciplinary research team of 14 full-time research team members, of whom 11 are computer science postdoctoral fellows or graduate students. And I also have clinical research fellows and bioinformatics expertise on my team. So my research background was a PhD in medical biophysics at the University of Toronto. Prior to that, I'd completed all of my medical training at McGill and then at Mayo Clinic in Minnesota. But then I did my research training here. And so that, I think, was a highly interdisciplinary background that then enabled me to lead such a highly interdisciplinary research team wherein all of us, who speak different languages meaning skill sets, can come together to generate and create new knowledge that can serve our patients to provide really personalized care. So the focus of my research program is to both develop and deploy AI tools across our clinical setting to optimize and personalize the care of liver transplant recipients. The inspiration for that was because in transplant, it's a constantly dynamic field. So we take care of we evaluate very complex patients for transplant. But the reality is that whoever was eligible for transplant 10 years ago will still be eligible, but perhaps there are new indications or new types of patients who are now considered eligible because of the dynamics in medical care. So, for example, cancer was an absolute contraindication to transplant until 5 years ago. If someone had a history of CML, we would say, well, being a transplant recipient, you're on immunosuppression, we will increase your risk of recurrence and very aggressive disease. So the reality, just to summarize, is basically that our patient population is so complex. There are so many different patterns in the clinical features as well as the laboratory tests that we're examining. And it's very difficult to then determine what is the best treatment or what is the best approach to caring for that individual patient in front of you, because that individual patient in front of you represents the confluence of different factors. So our human brain can basically account for 7 variables at a time, or 7 characteristics at a time. But the reality is that there's so much historical data. There's also a number of variables that you're considering when you see that given patient in front of you, that AI as a co-pilot could potentially help you do a much better job by having trained on a very large amount of data to then help fine-tune that individual patient's care. So that's really the sort of inspiration for my research. And some of the other inspirations are, one is witnessing disparities on the liver transplant waiting list. So the reality is that we take care of a very heterogeneous patient population. And so it's very difficult to rank patients based on their risk of death or dropping off the wait list because there's so much heterogeneity. So we have developed an AI tool that considers all of those multiple characteristics and historical changes to better rank patients on the wait list, and that we anticipate would remove disparities that currently women, as well as those with certain subtypes of liver disease, experience on the wait list. Another interesting tool we have developed is to remove subjectivity and make the process of candidate transplant decision-making much more objective. And I'm happy to talk about that. But overall, all of this to say that we work very closely with patient partners as well to build their trust in such research and such tools and inspire that research. And so I think overall, in terms of trust in science, I think it's very important to work with patient partners and other key stakeholders in the healthcare community to then build trust in science, because really it's the inspiration that comes from our clinical interactions with our patients that then will inspire the work that we do and finally help us build trust in science.
Thank you so much for those answers, just to understand your work. So I think, we've taken from this initial discussion the role of technology, right, and the role that plays in a democracy, something that can enable, right? We've talked about our healthcare system, and there's areas to improve, but hopefully approaching it from a place of optimism. And we've talked about increasing complexity, and so how can we combat that with technology, but also while building trust. So given those wonderful introductions, I think we have to sort of pivot now and think about where healthcare plays into this discussion. So freedom of expression is obviously a very important tenet of democracy, people would argue. But misinformation, though, has played a very substantial role in a deleterious effect in the health of the public. So for instance, we know that last year Canada lost its measles elimination status. During the COVID pandemic, there were, public health introduced restrictions, and a lot of people criticized those as infringing on rights. But at the same time, they had to be justified because they were protecting the public or coming from that perspective. So how do we balance, right, scientific guidance as something that the public has a right to, while also remembering the ideals of freedom of expression and the fact that we exist in a public that will have very diverse values and priorities? And Dr. Nowak, I'd like to start with you.
I think I'll be brief because I'm curious what my co-panelists want to say on this. What I did notice during the COVID pandemic, we saw a number of different studies that showed that people trusted advice from their primary care professional, whoever that was, usually a family doctor. And I think of the number of times I heard someone say to me that, I tried to get a family doctor. I tried to get in to that visit and I couldn't. And that's why I went online. That's why I went on, TikTok. That's why I went on Reddit. That's why I went to some other health professional that may not have the credibility or the training to speak in a way that's science-based on vaccines. And those were some of the root causes behind disinformation, misinformation, and people having incorrect information about not just vaccines, but then other health-related topics. So I'd say that that foundation of having a trusted partner in health, that is a family practice or a primary care professional, is so important to then building up credibility and trust in the rest of the healthcare system. And then, since we're here, by extension in other public institutions.
Thank you. Dr. Bhat, does that resonate as well as a physician, but in a different setting than primary care, perhaps?
Yeah. So I would agree with Dr. Nowak. Certainly during the COVID pandemic, our transplant recipients would, they were quite anxious and scared, obviously, early in the pandemic, being immunosuppressed, so being on anti-rejection medications, they were at much higher risk of infection. So particularly before the vaccines came out, there was a lot of, and any successful antiviral medications to treat COVID, we did have, unfortunately, several people pass away due to COVID-related illness. And in that very high stress, high tension environment, I mean, our transplant recipients would often contact us. I mean, we have transplant coordinators, so our transplant coordinators are really their first point of contact with our transplant program, and they would be, relying on our program for their care and sources as sources of information. I did also want to comment potentially on the differences in public health care and private health care in terms of trust. So I did my fellowship at Mayo Clinic in Minnesota, and obviously world-class physicians, like my mentors were amazing. Now, certainly they had, excellent relationships with their patients, and so highly trusted. But I think overall, in the public healthcare environment, there is perhaps a bit of caution in terms of our testing, but also like we will discuss with our patients different options, and they know that we're not going to be swayed by certain costs or certain other considerations like insurance, etc. So like when I order a test, I'm not thinking, oh, will this person's insurance cover it, or so there is a greater deal of trust, I think, that we're fortunate to have from our patients, because they know that we're trying to make a decision along with them that is in their best interest, considering their unique circumstances. So I think, even when it comes to very difficult discussions, which we often have in transplant, there is a greater sense of trust, I think, overall, that we're working together to make the decision that is in that patient's best interest, and that really follows the criteria that we have in our jurisdiction around, whether it be transplant candidacy or transplant care. So I just wanted to make that comment. Like I think, trust between a patient and physician is very important, and I think also the longer term sort of relationship that you build, or say myself and my transplant or my colleagues in my transplant clinical practice build, are quite important. But even beyond that, there is this additional level of trust that I think comes from the type of practices we have in this public healthcare environment.
Can I top up? So I think it's important to name the areas of healthcare where we do see an enormous amount of misinformation, disinformation. I'd be curious to know why these areas have that amount there. I think of when people are at their most vulnerable medically, the patients that you care for during the most difficult times of life.
Yeah.
In cancer care, we see a lot of misinformation there. Women's health, huge amount of, I think in many ways, possibly corporate influenced misinformation or not. There are these streams of misinformation. I'd be curious to know why those are some of the patterns that we're seeing.
Dr. Snyder, do you have some thoughts on that, being a
Yeah, well,
historian?
I do, but I'm going to play by the rules and answer the question that was asked first. No, because and actually it flows very nicely from the remarks about trust. The question was about the tension between freedom of expression, i.e. not wearing a mask, and wearing a mask, i.e. public health. And as I see it, a lot of usually these apparent tensions between freedom and the public good break down if you actually take the idea of freedom seriously. Because usually the idea of freedom that's put on one side is a very narrow idea of freedom. But if you think more broadly about freedom, then the tension releases and the opposition goes away. So what do I mean? I mean that, first of all, we're only free in our bodies, right? We can't be free any other way. We don't exist any other way. We only exist in our bodies. We're only free in our bodies. And a lot of the way we talk about freedom misses that. And insofar as we've built societies where people can be free, it doesn't have to do just with the government leaving you alone, which is the common, liberal or at least American way of talking about freedom. Insofar as people actually have freedom in their lives, it's because their bodies have been taken care of in some way. Because there is prenatal care, because there's natal care, because there are vaccinations, because there's access to family doctors. All of those things are, when they are built in, have created the lived reality of freedom that we have. I mean, and so as a historian, it's not hard for me to formulate this because I have a sense of what it was like before all of this happened. And people were unfree up until, the 20th century, essentially. Not only and not even chiefly because governments did bad things to them, but chiefly because they were constantly getting, I'm just not going to list all the terrible ways that people regularly died, right? Like the basic status quo is just so fundamentally different before the onset of vaccination and public hygiene, right? The things that we now take for granted. And what I would do is I would merge those things into freedom. I think freedom actually, I wrote a whole book about this, but I think freedom actually has to start that way rather than starting from I'm momentarily irritated because there's something that I don't want to do or the government is telling me to do something. And I think if we frame it that way, that these societies that we have in which we can be free have to do with knowledge about the body and particular kinds of health practices, then the discussion about masking looks a bit different. Because, yeah, sure, I have freedom of expression, but other people also have this bodily-based freedom not to be afraid of death, which I would argue is, not even so much a contrast. It's just like, yeah, if we're talking about freedom, let's consider both of those kinds of freedom and see where we end up.
Yeah, thank you so much, everyone, for those thoughts. Thinking a little bit more about the physician shortage crisis that we are facing. So if democratic legitimacy does depend on citizens actually being able to access those services or essential services, then how should we understand the primary care physician or just physician more broadly shortage crisis in Ontario, Dr. Nowak? Do you believe that delay in care is a democratic trade-off that is fair for universality, or is it possible that that could undermine trust just as deeply as exclusion due to cost or financial reasons that we more normally associate with, let's say, an American privatized system could?
Mm-hmm. Yeah, look, so the question is around, is it okay if we have a universal system, in some ways, a universal system, that people wait to get access? And I think of what I shared earlier around our Canadian healthcare system. We have world-class doctors and nurses and health professionals, world-class hospitals, world-class outcomes. If you can get through the wait, and actually, the wait is heartbreaking for many people. It's probably many of us in this room have experiences like this. Let me tell you what the wait looks like. Right in Windsor, I was meeting with a teacher who needed a hip surgery, and they were in pain and agony off work. Weeks turned into months. Now they've been on a wait list for 2 years, just trying to get through the system. That's what a wait looks like. In Rainy River, I was meeting with a family that was taking their grandfather to the emergency room with signs of a stroke. And they got there, it was the winter, and the emergency room had a sign on the door that said, ER closed. And the next one was 2 hours away during great weather. This was the winter. They weren't getting there that day. That's what a wait looks like. In southwestern Ontario, we had a family practice open a few months ago. This was sometime towards the end of last winter. And as early as 2:30 in the morning, there were already 1,000 people lined up just to try to get access to a family doctor because their waits were so long otherwise. So that's what a wait looks like. It's not just an academic exercise of universality versus waits. This is actually hurting people and harming by making them wait. So it actually does hurt trust when we do make people wait because it hurts health. People are reaching out to the healthcare system and not getting what they need. And in large part, that's not because we don't have a world-class healthcare system here in Canada. It's because we make people wait. So there's no separating the conversation on wait times, access, from the conversation on trust and people getting exactly what they need from the healthcare system.
I wondered if you could speak a little bit more, just as a follow-up, to the comment that you made about outcome, that we still have very good outcomes at a population level. And so someone might say, despite the wait, we seem to be still faring relatively well. Could we be doing even better if the waiting issue was maybe addressed? Or do you think that is then something that, should be overlooked or maybe is exaggerated? It's frustrating, as you said, it causes harm in the sense that it's very agonizing to wait, but are they maybe not zooming out and looking at the bigger picture because at the end of the day the outcomes are good? Or is that still not quite pinpointing the issue?
Yeah, you know what, I'll say in Canada we have a tale of two cities for our healthcare system. We have people who have access to strong primary care and a family doctor and people who don't. And if you do have a family doctor, you end up using the emergency department less often, you save hospitals for the folks who need them, you get cancer screening, you get preventive care. Studies show that you actually live longer if you have consistent relationship with primary care, family doctor, and at a lower cost to the healthcare system. So that makes our health system more sustainable for years to come. At the same time, for people who don't, or people who lose their family doctor, I don't know if anyone saw this, but there was a study recently on what happens when you lose your family doctor and what happens to people who are unattached. What did they share? They saw enormously worsened health outcomes for people who don't have a family doctor or who had lost one recently, especially for people who had multiple different health conditions going on. So we have a tale of two cities. We have people getting excellent care for those folks who do have access to primary care, and yet people who don't are being left behind. And that's why this is one of the most fundamental things that we can do is getting everyone connected to primary care in some way, maybe through a team, maybe through a family doctor's office, and restoring that sense of everyone should at least expect that level of care from their healthcare system.
Thank you so much, Dr. Nowak. I want to turn the conversation to talk more about technology. So I know, Dr. Bhat, you do a lot of work with AI. And so AI is often presented as a way to improve efficiency, reduce delays, and help to optimize processes. And so these technologies are advancing at a faster rate than the public can keep up, right? And so how should democratic societies manage the gap between this technological speed and social trust from the public?
Yeah, that's an excellent question.
Do you mind just using the...
Sorry. Yeah.
No worries.
Okay. Yeah, that's an excellent question. So I should also mention that I'm partnerships lead with TCAREM, which is the Temerty Center for AI Research and Education in Medicine. So this is a national network of healthcare AI institutions based at the University of Toronto, and we certainly have various activities, seminars, educational opportunities for both trainees as well as the academic community overall. So In terms of AI technologies in healthcare, I would say that the actual implementation of AI in hospitals is quite variable from one institution to another, let alone one province to another. So if you look at the Toronto, University of Toronto affiliated hospitals themselves, it depends on whether the hospital has decided to make an investment into AI because they are relying on foundation money like philanthropic donations, etc., to actually provide the AI compute and that, ability to implement. Ideally, we would be able to implement AI to such a degree, say I work at Toronto General, as I mentioned, so to optimize efficiencies around scheduling visits, around writing notes. We often spend time, as we say, pajama time, writing notes. At Toronto General, so far we don't yet have an AI scribe, which we should, but we don't. The plan is to have it by the end of the year. But the reality is something different. So yes, ideally AI tools would be used to improve operations, improve efficiency. Operations as in resource utilization, not wasting. There's a lot of waste in hospitals, right? In inpatient care, we would try to kind of manage stocks of, instruments, gloves, this and that, medications, based really on predictions that are AI forecasted. So there is a lot of opportunity for improving efficiencies in healthcare with AI, but I think the level to which we are able to implement those tools has been somewhat limited. And say at St. Mike's Hospital, where they did have a very active AI deployment program, that was all foundation supported. It was not resourced by the provincial government, and so I think it has required hospitals to make decisions as to where they will invest, so that then they can reap the economic benefits and healthcare resource optimization. But it takes time to actually see the benefits of that even. So I think it does require hospitals to make those decisions that then will result in healthcare efficiencies. Now, in terms of, I think the question was, sorry, can you come back to the question? What was it around?
So the question was about the speed of technological advancement with AI, and the public trust in.
Yeah, so that's I think the speed of implementation has been limited, especially in provinces like Quebec, the maritime provinces, but we are seeing greater speed of implementation in Ontario, Alberta, and British Columbia. So for example, I do research, I have this CIHR grant, okay, Canadian Institutes for Health and for Health Research grant. So I hold a few grants that are national in scope, and we have all 7 transplant programs on that grant. But the ability to which people can participate in Quebec and the Maritimes is limited because they don't have AI deployment capacity. They don't have the ability to extract data in an automated way. Their charts are still handwritten. So, how can you actually involve them in research that is national in scope, especially if we are so dependent on data and we're ultimately dependent on, all of that infrastructure for deployment, right? Whereas Alberta and BC and Ontario are much more able to do this. So I think within Canada itself, you see inequities in terms of being able to deploy. In the US, there are some of these private hospitals that have been able to invest a lot into AI implementation. So Mayo Clinic, Cleveland Clinic, Kaiser Permanente, these are all, hospital systems that have been able to implement, and they do report having efficiencies. So I think ultimately it depends on some resource investment decisions.
I think that's a really interesting comment because I think the general public perception is that AI is just innovating too quickly and that they're fearful of changes and maybe the loss of a human element of healthcare. Whereas, so it's interesting to hear from your perspective that the concern is actually about limited implementation and not being a source of inequity perhaps in healthcare implementation. So that's actually very interesting. Thank you.
Yeah, and to follow up on you were describing the different types of AI, like you talked about admin AI for scheduling and writing
Yes.
notes. But I want to ask you about AI that can be used as a predictive tool to make clinical decisions.
Yes.
Now, you already mentioned that there is limited implementation for just the admin AI. Do you think that we will be able to see the use of predictive AI tools in the future? What would that
For
look
sure.
like? Yeah.
So certainly we already have such solutions across the TASN system, the University of Toronto affiliated system. We have, for example, an AI tool to recognize patients who are at risk of deterioration. In my own practice, we are currently we developed and have deployed via Epic, which is our electronic medical record system, a tool to predict cardiovascular risk in our transplant recipients, and so modifying their management accordingly. So in 52% of cases of patients who were reviewed with this tool, we were able to modify and optimize the management of their cardiovascular risk. So certainly we do have various clinical prediction tools that are in use. But these are kind of selected tools so far. So it's not like a broad institution-wide deployment of certain tools. So I would say also there's a lot of compute resource required. Depending on the complexity of the tool, it may be more or less difficult to implement via Epic. So for example, we had a very complex model. It's a type of model called a transformer model that we tried to deploy via Epic, and it was generating hallucinatory predictions. And then we had to which was, we had published that paper in a high-impact journal, so a few years ago, in Lancet Digital Health, so in 2021. And then I tried, then I said, okay, let's go on to this next step. Development is well and good, but we should actually try to use this to personalize care of patients. And then when we tried to implement this, we ran into this problem. So our data engineer was able to, integrate the solution into Epic and everything. But the transformer model was so complex, like it was considering 167 variables and then historical changes. So it just became too much for Epic to manage, or for our system to manage. So then we had to make it much less complex, considering a much smaller number of variables, and then it started working well. And now we are actually using it for cardiovascular risk prediction. So just to say that it's not straightforward. The whole implementation side of things related to AI is not straightforward. But I would say, the patient partners who work with me are very keen on AI implementation because they see it as a co-pilot in their care so that we can do much better at personalizing their care. And what we also do with the predictions is every time we have a certain, cardiovascular risk prediction, okay, so this patient has a 30% 5-year risk of cardiovascular event, you can then tell what it is in their clinical and laboratory characteristics that is the heaviest in weight in that prediction, meaning, okay, very simply, age, diabetes, perhaps they have a high immunosuppression level. So you can look at all of these parameters for that individual patient. And by doing that, we are also empowering patients in their care because they can look at that list and then say, oh, well, perhaps I need to work on this so that I can, improve my cardiovascular risk. So I think by doing that, we can help patients gain trust also in these solutions by providing what's called interpretability to the AI clinical decision tools.
Thank you. Dr.
I don't have expertise in democracy, so I'm sorry if I'm not like perfectly relating this to the democracy side of things, but
No, I think it's a broader discussion,
it's a very
right?
different world for me, but very interesting.
Yeah, and just wanting to learn about the work that you're doing, and
Yeah.
as you said, how you've had to think about the themes of trust and engagement, as you
Yes.
said, with patient partners and things like that. So that's excellent. Thank you so much. Dr. Snyder, so one of the more striking arguments that you have made in our malady, but more broadly in some of your talks, is that the American healthcare system is very predicated, if you can say, on fear. Fear of illness, fear of bankruptcy, fear of unemployment, because your ability to access healthcare is so intimately linked to your employment. In recent years, some provinces in Canada have been taking steps to privatize elements of our healthcare system. And so I would like to know what you would maybe say to these officials, and what do you think Canada ought to reflect on our form of healthcare historically, and how it may have supported, if that's your view, democracy, particularly in the current moment that we're facing as a country.
Dramatic pause.
Yeah. So thanks for bringing up the topic of fear. There are actually a couple. As we've been talking, I've been thinking about how these subjects come into my books, and they actually come into several books. And one of the books they come into is something that I wrote with my friend Tony Judt, the great historian, a book called Thinking the 20th Century, which I talked to him. We talked it out together because he was dying of ALS. And this is what we did while he was dying of ALS, was he wrote this book. And this notion of fear, I think, comes largely from him. He was a committed social democrat, but I think a social democrat from good historical arguments as well as from personal and moral conviction. And one of the things that Tony noticed was that the American political system seems to run a lot on fear, which is a good observation, and it's an observation that is more easily made from the outside. Tony was British and moved to the United States. And fear is so pervasive in the United States that we don't really notice it. I mean, I only notice it in the absence. I notice it when I go to other countries. So I notice it, we lived a good deal in Austria. When we go to Austria, I notice that something has changed. Or when I fly into Pearson as opposed to flying into Kennedy, I notice that something is different right away. Like my human ability to pick up 168 variables at the same time allows me to notice that something has changed. So I appreciate this. I appreciate you raising fear, because that's really, really important. Because if you're living in a society where, like this one, so the second thing is fear is very intimately connected to the body. Right? I mean, giving birth, and I won't say this as an observer, a multiple observer, it's terrifying, and dying is terrifying, and disease is terrifying, and there are all these things along the way they're very frightening, even in the best of circumstances. And you can make these things more frightening, right? You can, by not having natal care, or by not having hospices, or by not having access to family doctors. You can make all these things that are already frightening more frightening, or you can take them as an opportunity to build human relationships and effective practices which not only mitigate the health risks in a narrow sense, but also give you a sense of political and social and cultural connection to other people. So what we have done in the US, and so it directly connects to the privatization question, because what we've done in the US is that we've essentially commercialized the fear. Now, we've taken the fear that's natural, that's human, that's inevitable, given the kinds of creatures we are, and we've turned it into a source of profit. And so I appreciate your starting with the fear, because it's hard in Canada to articulate what it is that you have to lose, right? Because even when you're in the US, I know a lot of you spend a lot of time in the US, you always have this thing to come back to, right? And there's always the Canadian health system you have to come back to. And it's hard for Americans to understand the fear that they're living in because for them it's just the way the world is, right? So, when we evacuate a sailor from Greenland to Denmark to use the Danish, healthcare system, we really struggle to explain how that sailor could have access to that healthcare system, because what is a healthcare system, and how can he pay for it, and how can this possibly be working, right? We just don't have mentally the notion that you can have a doctor or have a hospital. What we have is that this is one more process that you pay for. So when you go in, even to the emergency room, with various kinds of, ridiculously horrible things that can happen to you, the first thing you confront in the American system is the question of whether you have insurance and what kind of insurance. That's the first thing you confront, which reminds you, in this moment where you might be afraid for your life, that you are nevertheless, right down to the last minute, a commodity. Right down to the last minute, right? That's the thing if you die after that conversation, that's what you're going to be thinking about. And I almost did, which is why I have this example in mind. And so I appreciate you're starting from fear for that reason, because there's an inherent terror which comes from being human, from knowing that you're going to die. For reproduction is difficult. These things are inherent, and then I really think that good politics begins. So this isn't just an element of something. It's not just an aspect of democracy. That good politics begins from recognizing that fear, that terror, and turning it around into something which can be positive and nurturing, right? Turning those fears around and creating from them a political community. And it's in that way precisely that the United States is not a political community. There's a lot of, because there's so much ambient fear, and it's not just that people are afraid individually, it's that those individual fears can then be mobilized. They can then be transformed. They can be turned against other things. The fears that you have that are natural and have been magnified by commercial medicine can then be turned politically against whatever, African Americans, immigrants, Canadians, when we're having a really good day. But that fear then becomes, it's a permanently produced, regularly produced political resource. And it's not just that it's a problem for democracy. I think it's fundamentally inconsistent with democracy, because democracy isn't just about going and voting every so often. Democracy is about believing that you're part of a people. And if you're afraid so much, and if you don't have a relationship with a doctor that brings, or a nurse or whatever, that brings you into a sense of a larger community, you don't, in a fundamental sense, believe that there is a larger community. So I'm going to answer the question in this kind of abstract way, because I can't, I don't know exactly what they're talking about in Alberta or whatever. I assume it's Alberta.
Sadly, some parts here as well in Ontario, but
okay.
Other places as well. And
Okay, all right.
Wouldn't expect you to know the particulars, but more.
Okay, yeah, but just so the thing that I would say is this: that once you open the door to the body being a commodity, it's very hard to close that door again, because precisely the fears, and this goes to the earlier question that Dominik had about why certain things become the targets of disinformation, precisely the things that are most frightening, like birth or cancer, but just health in general, those things can be very easily monetized. And once the temptation is there to make money from this stuff, it is a very short step to organizing hospitals around keeping people sick in the right way for the right period of time, or something like that, which is what we do. That's how, sorry, but that is what, in fact, what we do. You could be the wrong kind of sick, too bad. You could be the right kind of sick, but for the wrong period of time, too bad, right? And then once you open that door, then a lot of money is made very quickly, and that changes your politics. So about a sixth of our GDP is from so-called healthcare, right? In the U.S., not yes. When I say our, I'm still. Sorry. That's all right. That was a very interesting exchange, because you don't have anything to be sorry for, which is almost always true when Canadians say sorry. So about a sixth of our GDP comes from what we call healthcare, and that shouldn't exist. Like that part of our GDP, I would count that actually negatively if I were going to count actual GDP. But in any event, it shouldn't exist. But if you imagine that Canada could become a place where 20% of your GDP comes from essentially the commodification of the body, you're looking at a very different country. So, I mean, what I would say exactly to these local health officials, I don't know, but at a kind of Canadian level, that's the transformation you're talking about. Once you commodify the body and you allow a huge amount of money to be made, then these fears, the normal fears we have because we're human, become an element of capitalism, and it's really hard, if not impossible, to come back.
Thank you so much. I really appreciated your comment on, the right type of sick and one that fits in within that kind of model. As Dr. Orbinski said at the beginning, my research is predominantly around rare diseases and how we can improve data collection, but outcomes for people with rare diseases. And I can tell you that one of the key barriers for them is just beyond getting a diagnosis, it's getting treatment, because of course there is not a monetary investment or interest from the various players for that a lot of the time. So I sort of had access to that issue, even though I have the benefit of being in Canada. So I do want to sort of now open it up again to the panel and think about the issues that you're most passionate about in your work, where you're thinking about collaboration with partners or relationship building, perhaps with patients, etc. And so who do you think bears the greatest responsibility right now for delivering trust? So trust in science or in healthcare. And what do you think would mean or look like meaningful change, maybe a couple years down the line? And Dr. Bhat, why don't we start with you? Being the AI person, I think everyone is very interested in where AI is going and how it could be maybe more collaborative, for instance.
Yeah, so I think trust in science needs to start early, like, when children are in their foundational years. So, one thing I notice in our educational system is that science seems to be introduced a bit later than it is in other countries. So perhaps we need to introduce science earlier. Mathematics certainly is foundational. There should be much more accent on these, I think, in our educational system, because I think, building trust in science really does stem from that time, So, and then over time, having good role models along the way in your life is critical. So I think the quality of the teachers will matter at the elementary and high school level. And then beyond that, I think trust in science and in healthcare research will really come through sort of interdisciplinary discussions and the ability to generate new knowledge from those interdisciplinary discussions. So I think, one very important thing in my mind then finally is also the ongoing conversations with patients and their understanding of their illness, building that trust. So, certainly as a physician, I'll try to ensure that my patient fully understands their diagnosis, the treatment approaches, how I might be using AI to personalize their care. So, all of this involves, regular building of trust with patient partners, with patients, and with the, for me, the transplant community at large within Canada. So, yeah, I think that pretty much, ultimately, I would say really that trust in science is something that should start very early in children's education.
Thank you. I think that's something we haven't thought about enough, and I'm really interested to hear that comment.
Yeah, the reason I said that is because, I did 2 years of schooling in India, and there I was struck by how many subjects they had and how much I had to memorize during those years. I mean, it was like, I had biology, chemistry, physics, and then biology was even divided into botany and zoology. I mean, this is like now many years ago now, but it was just like so much was started and very early, like in elementary school education. There was, and
Almost values-based. It's something that's valued.
It started very early. I mean, it was like a private school, but I think perhaps we need more of that kind of exposure and education early in kids' lives, because right now I see my kids. They're at a French medium school, like a lycée français, and they don't have science yet. And my son is in grade 5, so I would have thought there would be some solid subject in science by now, but I haven't seen that yet. So I think that's critical, actually. Science and math.
Thank you. Dr. Snyder, same question, but maybe you want to return to the idea that you said at the beginning about technology having to be something that is enabling. Obviously, we're always having to think about technical advancement, and so maybe that is something that has actually been disabling when it relates to trust in science, and so I'd love your thoughts.
Okay, a couple of quick thoughts, and then I'll get to that. This notion, so first a plug on my Substack, which is called Thinking About. My colleague Sarah Silverstein, who's been a guest here at Massey, wrote an essay called Consumptive Capitalism, which is a reflection on the relationship between our current American politics and the expansion of the commodification of the human body, which reflects back onto an earlier era before we had all of the things that we have, right? So it's about how replacing the notion of health with a notion of wellness can be a deliberate move to expand disease and therefore expand the possibility for money making, which is something which is happening in the US and is directly connected to whom you trust or what you trust. And then the second thing I wanted to say is that, because you asked the question earlier about collective efforts that we're making, and the last collective effort that I made that had to do with healthcare was raising money with a lot of other people, of course, to purchase automobiles with drone jamming capability that could be used by Ukrainian medics to retrieve the wounded from the front. And I just wanted to mention on today, which is sadly the 4th anniversary of the full-scale Russian invasion of Ukraine, that among many other things, there's a lot of medical knowledge that has been gained in this war by Ukrainians. And there have also been a number of really good initiatives from the Canadian side and a lot of really good efforts. So if you're thinking of doing something today on this 4th anniversary, there's the Canada-Ukraine Foundation, which among many other things is supporting medical care of wounded soldiers in Ukraine. So on tech, I'm glad you asked, because I think it is a bit the elephant here in the room. Because when I think about education and moms, and like parents, parents are terrified of AI. They're terrified of it in general, and at least I'm talking about polling in the U.S. So maybe it's maybe like everything else, it's slightly gentler here, but I doubt it honestly. Parents are terrified of AI. Like the number, and it defies politics like very few issues do. It runs close to 90% of parents are worried about what AI is doing or is going to do to their children. And so, it's true. I completely agree that there should be more science and more math, especially like basic science, basic math, building blocks all the way through. I'm very much on that side of the argument. But the problem is that well before kids get educated, basically from the cradle now, they're being exposed to algorithmically driven, attention capitalism, which is only getting worse with the things that we choose to call AI. And so we have this tension, right, where there's a massive public health issue which is directly related to social media as it now blurs into AI. That is a big public health issue, which parents are rightly concerned about. And so when you start from that status quo, and then you go into a public health setting or a hospital setting, and you say okay, now we're going to use AI, and it's going to be great. Presumably, there's going to be some kind of tension there, and so which doesn't mean that it's not going to be great for the liver transplant, but it does mean that we're dealing with a situation. We're dealing with another public health situation. I would put it that way, which is the which has to do with young children, and the younger you go, the worse it gets. And so what I'm trying to say is that whether or not kids learn science and math, they're being exposed to the sharp end of this thing that we're calling artificial intelligence very early on, and it has terrifying consequences from the point of view of an educator or from the point of view of a parent. And so that's something that has to be brought in. And I would just say that, like, in addition to talking about the specific things that these technologies can do, I think at every step we should be inviting the human ethical conversation along the way, because it is reasonable to worry what's going to be done with this data. Like in the US right now, the Pentagon is quite literally trying to build a predictive system about which Americans are going to resist the Trump government using AI right now, right? They're doing this right now. And so the notion that, like, you might be a little bit concerned about predictive things, there's some justification for that sort of thing. So as we use these technologies, I think, like, at every moment we have to wrap them as humans wrap human ethical questions around them, because even if people don't understand them, which frankly they won't, because almost nobody understands AI, which is part of the problem, right? Even if humans don't understand them, they have to deal with them, and so we have to make sure that we don't just say this is good because it's tech, or this is good because it's efficient, or this is good because it's progress. We have to make sure that we're taking into account precisely the human side of these concerns, or else the good that we can get from these technologies is going to be stopped, and the risks that arise from these technologies isn't going to be hemmed in. So thanks for asking that.
Thank you. And Dr. Nowak, would love your thoughts as well as the closing comment.
I think part of the question, so media tip is always, in a several-part question, answer the part of the question that you actually want to answer. So the part of the question that I want to answer is, whose responsibility is healthcare in Canada? And obviously, there's a responsibility for associations, the professions, doctors, and so on. But I'd say there's a citizen responsibility as well. It's on all of us, right? And one of my favorite things that I got to do that was good for my soul when I was president at the Ontario Medical Association was actually go to some of these communities. I think of Timmins, Sioux, Cornwall, and so on, many communities across Ontario. And what I had booked in my schedule was, meeting with doctors, physician leadership meeting, that sort of thing. But when we were driving there, I'd always ask the team to drop me off somewhere, just anywhere in the town, that community, and I'd ask people. I'd walk from store to store and ask the people working in that store, how do you feel about your healthcare system? Is there a doctor that made a difference for you recently? Bless you. And just the things that they would share were beautiful. And one of our roles as an association was to make those private conversations that people were having about healthcare public, right? Whether they were good, things to celebrate, or whether they were not so good, things to yearn for and make better. But then the second piece of that is showing people that there is a sense of self-determination in our systems, in our institutions, that if our healthcare system is to be better, it's up to all of us to make it better. And there are ways to do that, even if we're not health professionals. I think of panels like this, but then also the feedback sessions with governments, also areas where you can volunteer with hospitals, also making some of your own private conversations about healthcare public, share them with your MPP, and so on and so on. There's so many ways to actually get involved in this process, all the way up to people with lived experience or patients leading large parts of our healthcare system. And that's where Catherine is really admirable, because you're incorporating people with lived experience into how we treat and care for and do science. I also think of examples like some of the Ontario health teams that have patient or lived experience, expertise, co-chairs. So people with experience in the healthcare system as their expertise, as leading that local healthcare system. And then advisory groups for hospitals and so on and so on. So there are ways to get involved. As Professor Snyder would say, pick an institution, We think it should be healthcare, and defend it. And that's for on all of us to do. Yeah.
Okay, so thank you so much to our panelists for the wonderful conversation. Now we would like to turn the attention to the audience so we can get your thoughts. Yeah. Okay.
Competition.
Thank you. It's an excuse to get up and stretch. First of all, I want to express my appreciation to each three of you panelists, because in your own way, you have articulated, manifest the problem in our civics. There is fear. And also there's a lack of what I call moral epistemic courage in terms of political leadership. You're looking at long-term, not transactional issues. And is there the leadership? Do we have the capacity to admit that we don't know? Because a wise individual, the more I know, the less I understand. The more I understand, the less I know. And healthcare is what I call one of the Grundnorms in terms of our civics. I know this from my experiences abroad, primarily now in sub-Saharan Africa, where you deal with different type of systems and people. And people can be very powerful. And politicians, they are elected to be re-elected. And then once they become part of the system, they may go in with idealistic expectations in terms of, I'm going to do this. And suddenly the system grinds them. And it's also very, very corrosive. And if I were to pose a question to each three of you, if you are optimistic, explain why you're optimistic. Do we have the better angels within ourselves? And absolutely, the citizen is of prime, fundamental, ordinal essentiality, notwithstanding whether he knows or not. But emotion is also fraught. We are in, I don't want to say perilous times, north of the border. And one of my classmates is now part of the Trump administration from the Kennedy School. And I'm not going to mention whether it's a he or she. But the point being, in a sense, it's...
Pronouns are awkward. It's not. So I don't believe in. I mean, I agree with what very much with what Dominik said at the beginning, but I frame things in my own politics in terms of hope rather than optimism, because optimism is a way of seeing things, and I think people do tend to be optimistic or not, and it's hard to work yourself into being optimistic if you're not an optimistic person, whereas you can work yourself into hope, and the way that you work yourself into hope is by doing things with other people, because it always turns out that there are people who are more competent than you, more imaginative than you, more courageous than you, or all three, and all the kinds of things we're talking about, and essentially any other political issue, which as you say is not transactional, which is long-term, involves some kind of collective work. And so I think I am hopeful, because whenever I do become active, I find that there are people who are doing interesting things and haven't given up. So I mean, and the second thing I would say is that I don't think we have a right, especially in Canada, God forbid, I don't think people have a right to say, oh, like it's so dark that there's no possible way we can get out of this, because compared to other predicaments that other folks are in, it isn't so bad. And also, whether or not you can be politically effective depends very much on your own personal sense that there are little victories that you can get along the line. So, I mean, I get accused of being a catastrophist all the time, and I'm not sure why, because I constantly am thinking like, okay, yes, things could go very wrong indeed, but that is precisely why you have to be at work on a whole bunch of little things at the same time, because then you feel better, and also working on the little things can tilt towards the big things, right? So, like, if there's a rational answer to your question, it's that we are at a level where we can have conversations about things like health, where macro political changes based upon discussions like this can then have lots of micro changes in people's attitudes and their own sense of hope. So, yeah, yes, I mean, I'm going to be affirmative in response to this question.
I'll share a thought on this one as well. So here's how I'd frame it. Optimism in healthcare right now is realism and hope. Realism is this idea that governments are looking at the health budget and are feeling the pressure, right? They know that a strong healthcare system is dependent on a strong tax base and a strong economy to sustain it, right? So there's a one-sided piece there of you need a strong economy to fund through tax dollars strong Canadian healthcare. and they're seeing that, they're seeing a slump in the economy, and they're saying, okay, things are going to be challenging for healthcare because we may not have the funding to sustain it. On the other hand, what not every politician is capturing is that if you look at Tommy Douglas's original vision for Canadian healthcare, healthcare is central to a strong economy. It's good for workers, good for corporations, good for investment. It's a magnet for talent and science and innovation, and it actually contributes to a strong tax base through healthcare, but then also through so many other ways of economic sustainability. So there are two sides of that. There's a realism that some politicians are capturing, but then there's also a very hopeful argument, a real argument, and a Canadian argument to be made that healthcare is central to rebuilding a strong Canada and a strong economy. And there's an economic argument to be made for bolstering healthcare, especially right now at a challenging time.
Just making sure that it's on. Okay. Hi. My question has kind of evolved as you all have talked, and you're all speaking about really complicated things. I'm a pharmacist, early career pharmacist, from Sault Ste. Marie. So when you mentioned the Sioux there, I was very excited. And it's complex, but undertone of everything that you've said is really access, whether it's access to information, access to understanding, access to care, whether it's specialist, primary, or information. So I'm wondering if you can comment on the complexity of rurality, or maybe in a social context, but also in access context, whether from specialist lens, primary care, or more of a democratic understanding from a historical perspective. Thanks.
So that's an excellent question, and I think there have been studies demonstrating that rural location can affect access to certain types of care. So in the transplant context, as a subspecialist context, yes, there is evidence to suggest that those who live in urban settings will have greater likelihood of being referred to a transplant center, first of all, and then go through the evaluation and have, greater connections to the transplant program so that they can have better outcomes after the transplant. So how can we address that rural-urban divide? I think this also perhaps requires education of physicians in the community setting as to when is the right time to refer. In my own practice, what happens, and I've not looked at the numbers, but I would say certainly people referred from more remote locations tend to be referred to us a bit later in their disease, and it becomes a bit more difficult to optimally care for them as opposed to, say, those who live in an urban setting. So I think you're absolutely right. Now, how can we address this? I think it's through community education, but perhaps a better, streamlined referral process, AI-driven referral process, and, more kind of operations type like framework to enable better access.
Can I just say, I thought that was a very conservative answer around how challenging things are in northern or rural communities. And anyone else from the north or rural Ontario? Or where are you from?
Quebec.
Quebec, yeah. Okay, beautiful. And then from the Sioux, right? Anyone else? I think I saw one more. Yeah, okay, beautiful. How far away is that from a big urban hospital? Yeah, okay. And what I'll say is especially including for Ontario, north, rural, different, northern rural, also different, and all of the above, a different planet than healthcare in the cities. It's a different planet. So when we hear kind of the studies showing may impact access, may be different, everything like that, actually there's an enormous impact on access. People get delayed care. If you get cancer in a northern rural community, you have the choice of usually moving for months at a time from your family, your support system, and getting cancer care, or staying close to home near your support system, right? And the list goes on, right? People have challenges through wait lists. If you want a skin cancer procedure, you probably have to travel a few hours. If you want to go to an emergency room, if there's one open near you, it's maybe an hour, maybe 2 hours, maybe 3 or more during the summer, during the winter. Good luck, right? There are so many challenges in northern rural that sometimes we gloss over as policy people in healthcare that are so important to embrace and get better and elevate, because everyone deserves at least some foundation of healthcare in Canada, no matter where you live.
Can I just add a couple of quick points? The first is it's about pharmacists. So it's very important when you're in a society where there are multiple points of access to healthcare. It's important to recognize those things. And a pharmacist isn't always a point of access to healthcare. A pharmacist can also be just somebody who pushes the pills, over to you, right? And I've lived in different countries, and the way that pharmacy works is quite different. And in Canada, I found that pharmacists are quite chatty, which I appreciate, because there are, like, they ask questions and things. But it's quite helpful actually for them to be chatty, because often something comes up which you wouldn't have thought of, right? And so having points of contact with the healthcare system, which are not just the doctor, not just inside the hospital, not just in a special, that's really significant. I don't know how much of a discussion that is here, but it's something that I've noticed that's been positive for me. But I wanted to just note a risk that's connected to this phenomenon, which is that in the U.S., where rural care is bad and worse, but also in our rural areas, there's no access to local news. So most counties in the U.S. are now news deserts. And those two phenomena interact. When there are no government services and there's no access to repertorial work, right? The result is that people very quickly think the government is of no use whatsoever, and I'm going to vote my anger. And that is quite relevant for democracy, that combination of lack of access to healthcare and lack of access precisely to local news that's reported.
Well, I am a member of a growing Canadian League of Ancients who will yet maybe bring the health system to its knees. You've answered one of the questions about the pharmacist, because that's my primary. I've got a wonderful family doctor, but I try to be educated and not go to him too often. But there's an element, I think, that we've been talking about, which is citizen education, getting it across to people like me and lots of people what they can do before they afflict the rare family doctor who's still around. I don't know how that's done, but I'd be interested in any observations you might have and how we can better educate each other, short of MAID.
I'll say one of the major advocacy successes that we've had in our healthcare system and then as a profession is the largest single investment in primary care in Canadian history, now happening in Ontario, right, with over $2 billion, a primary care action team, Jane Philpott leading, connection to family doctor primary care team for everybody. Yeah, and as part of that, a big part of that vision is you don't always need to go to your family doctor for things, but you should at least be connected to that team. And that's where we've been advocating for primary care teams, including folks that deal with health education, health promotion, link workers, the whole conversation on social prescribing and the social determinants of health and how big that is and emerging in Canada. And those would be team members for those primary care sites. And that's the future. What I will say is I'd push back on the idea that a connection to a corporation and a pharmacist working out of a Shoppers Drug Mart is an answer to a healthcare system and creating a primary care foundation for everybody. You want those pharmacists working in teams, ideally in connected teams with primary care, not just in big box shops. And there's a completely different level of working with the healthcare system when you get both, and that's the ideal for teamwork around the pharmacist conversation there.
Okay, I have a provocative question for Professor Snyder. So, after reading On Malady and thinking about, the issues that are afflicting the American healthcare system, and your principle, I'll call it the corporal principle, that you need a functioning body in order to participate in a democracy. Do you think? No, I know you didn't, but. Do you think that the erosion of access to health care for financial reasons and other reasons is potentially a cynical ploy on the part of politicians to reduce the capacity of the citizenship to participate in democracy? And is there a concern in Canada where we've seen the drip, drip, drip of the access to health care with the same, perhaps, intent?
Yeah, I want to be clear that I didn't say that in the book. I was concerned in the book with the connection between the body and freedom, but none of us actually has a fully functional body. I mean, not a single one of us. And that for me is like where the conversation starts. So we all have different levels of need, but there's not a single one of us that can get through a single day without some kind of cooperation having to do with our bodies, right? None of us is supplying our own water, none of us is supplying our own shelter, none of us is supplying our own heat, few of us are, so on and on and on. And so whether or not we're sick or how sick we are, I try to start from the notion that being alive in a body means that there's some kind of connection, and once one recognizes that, it follows, that you can either exploit that positively or you can exploit it, as in your question, negatively. And yes, it's absolutely the case. It's a negative. It's one of these issues where there's a negative feedback loop. So some people just want to make a lot of money out of healthcare, right? So private equity in the U.S. just wants to make money out of healthcare. Some people completely understand very well that if people are deprived of healthcare, it works for them politically. So in the U.S., there is a very specific demographic which thinks it's bad for there to be healthcare for everyone, because they think if there's healthcare for everyone, then other people will exploit it. And meanwhile, I'm very tough and I don't need it. And if you can get people into that situation, then they're going to vote for you because they're not actually going to be healthy in many ways. But they're going to think the main issue is like stopping other people from getting care. And in the U.S., this is very much connected to race, obviously. So yes, those two things work together, right? I can be trying to make money, or I can be trying to make people angry. And then when you get a coalition of the greedy, right, and the fascist, you end up where we are. So yes, and I'm not saying that every Canadian politician who's thinking about privatizing care is thinking along those lines, but people do have that thought that if I can deprive you of care, I can worsen your life in a way which is politically productive for a movement like mine. People do have that thought, yeah.
Pardon me, thank you. I suppose I could have asked individual questions to the three of you, but in the interest of time, I have a primary concern here. Am I being heard? Yes. I have a fundamental overriding concern here for the fact that, in my understanding, 5 to 6 years ago now, when we were confronted with a crisis worldwide, we were provided with a possible solution to that crisis. And when I asked my GP, my then GP, who is now at Women's College, very happily, and she could not tell me anything about this novel vaccine. And I was unable to provide informed consent. Now, I don't know if anybody here ever did provide informed consent for that, because it was novel. And I decided I would be part of the control group. So and I also heard someone recently online or on the radio saying, a young person saying, that she didn't think informed consent was really necessary anymore. And I've read Dr. Snyder's book on Black Earth and on tyranny, and I've read Shoshana Zuboff on IT and AI. I'm I'm concerned about this. Michael Pollan was speaking on The Current this morning with Matt Galloway about his latest book, which has to do with consciousness and with what makes us human. And artificial intelligence is simply artificial on the simplest level. I worry about the kids. I worry about the future. I have no children of my own, but I'm a retired high school teacher. And I and my great nephew is really into it. The most wired kid I know. But he's in university and he's learning. But he's not learning about informed consent. And there was a man once during the Nuremberg trials who gave his life to making sure that we have that. And I fear it's being lost. My doctor could not tell me what I was about to or not about to be injected with. And so I chose not to be injected. As I said, I'm part of the control group.
I think that's a question. Oh, really?
I thought it was clearly a question for you. Yeah, I mean, I think so. I'm going to pick up, following the principle that Dr. Nowak articulated the principle that you answer the part of the question that you like the best. There's actually there's a trickier version of this, which is that you assume that nobody remembered the question at all. I'm going to answer the parts where I think I might have something to say, and briefly. First, I think that I agree with. I mean, as a parent and as somebody who has taught inside and outside university settings, I don't think that we are being truthful with ourselves about the degree to which that social media, screen time, artificial intelligence is a massive catastrophe for human cognition. I think we are daydreaming our way through this, and I worry that institutions like the one that we are in will be impossible in a time frame of 5 to 10 years unless we take very seriously the notion that we have to have humans teaching humans in ways that are observed by humans. And I notice with concern the tendency of elite institutions to already be doing this, not because I'm in favor of their doing it, but by the time I left Yale, when I banned computers in the classroom at Yale, I was, I think, the first person to do so. That was 20 years ago. By the time I left Yale, it was up to about 25% of classrooms, and there's a reason for that. And I think at elite institutions, it will go up close to 100 soon, because there's no other way actually at this point of verifying the work that students are doing. I mean, in general, at least in much of the things that we're trying to teach. And so, and it's also very hard to overstate the degree to which young people are substituting questions to what we call artificial intelligence. The thing is that AI, what we cover with the term AI, is a whole suite of very different things. But young people use AI very often without any sense of guilt. Sorry, young people out there, you can tell me that I'm wrong, right? Guilt, remorse, or even like awareness that this is an issue, right? There's a problem that has to be solved. I'm going to solve the problem in the most efficient possible way. So in general, I'm very concerned, and I think like when we remember that like healthcare is about fundamentally about like birth and death. When I look at the trajectory of very young people coming into this world that we've made for them, I'm quite concerned that we haven't framed this in a broad enough way yet. So that was one part of your question. Informed consent, I'm with you there, and I think that the thing that I'm going to note here is just that the family doctor thing is much worse in the US. And the only way you can have informed consent is to talk to a human. And the human has to know what they're talking about. That's the thing but also it has to be a human. You can't actually give informed consent to a form, right? As we're asked to do so often. It has to be with a human. And that's one of the reasons, like it goes to the question of like the reasonable question of how do we know what we're doing when we go along with some kind of incredibly complicated procedure. There has to be a human who's good at it. And so where I want to land is that one thing I worry about, and again, like my encounters with the Canadian health system have been numerous, but not nearly as numerous as with the US one, and not nearly as dramatic. But one of the things that I worry about with doctors, I say this with love, is that the ability to communicate with other human beings is a uniquely human capacity, but which requires constant care and nurturing. We don't do it unless we practice doing it. And so all I have to say about informed consent is that it has to involve an interaction with another human who has practiced talking about what these things are. It can't be, you can't give informed consent to a machine directly, but it also has to be with a human who is practiced at having these kinds of conversations, right? And as in the US, as I've watched the human beings recede, like physically recede behind machines, like nurses literally, not that this is unknown in Canada, but literally stand behind machines. Like doctors are literally staring at their Epic thing, like trying to poke at it, trying to figure out how they're supposed to actually enter this thing. I've had entire encounters in very good hospitals, world famous hospitals, which involved zero eye contact, right? So this is a very elementary, like patient level response to this question. But I worry also about how AI is training our physicians, or how technology is training our physicians without their recognizing, and again, I'm sure this is Canada, so it's all much better here, but how how technology trains physicians and other medical professionals without their realizing that they're being trained. Okay, so those are some riffs which I hope are relevant.
Overall, if you look at human history, there have been technological innovations along the way that have basically transformed the way we do things. So, industrialization several, over 100 years ago resulted in so many changes in the way things were manufactured. And so it meant that people had to retool, reskill, so as to remain competitive and within the workforce. So I think the reality, for me, I'm much more optimistic about AI implementation to better care for my patients, because I think overall, yes, it's important to proceed with caution when it applies to social media and so on. But the reality is that the next generation of students really do need to understand what AI tools are, what the benefits are. Like, they need to be very aware of what it can help them to do, how it can help them to contribute to society in more efficient and better ways. So I think it's not necessary to be fearful, but I would say, proceeding with caution and awareness, being educated about what AI can help you do and what it is not, good for, and what are the negative aspects of it, I think is very important, because I think it's important not to confront it with fear, but rather appreciate, be realistic about what it can help you do. And I think, from a clinical standpoint, I think there are a lot of things that we can improve about the way we deliver healthcare. So the reason I say that is because, say, 10 years ago, when I started as a hepatologist in the transplant center here, patients were much less complicated. So, now I'm evaluating a 70-year-old with a long-standing history of diabetes, chronic kidney disease. They have a history of coronary artery disease. They survived a heart attack, 10 years ago. And they also survived cancer. Like, there's so many different things there. It's so complex. And, when you're seeing an N of 1, like, a few patients, I think you really have to kind of, have AI sift through, the Canadian experience or the US experience to then be able to say, for your individual patient, what is the right way? Like, what is the best way for me to take care of this patient? And I would say, with ambient AI scribes, there's a lot more potential for us to directly speak with patients and interact with patients. And that's actually what I would say is the experience of centers where they have AI scribes now. So at some of the hospitals in the TASN, there are hospitals with AI scribes, and they're better able to interact with patients. They're able to spend more time in communication rather than spending all of the time typing. So I think, overall, my message would be that as someone who's very much in this area, like, I think we have to look at AI, yes, critically, but also assess, where is it that it can actually help us improve healthcare outcomes, efficiencies, operations, especially in a resource scarce environment that we have now. Because, for example, like when I have a very complex patient, I want to order various tests to ensure that I'm delivering the best care. And as patients become more and more complex and are aging with, all these multiple comorbidities, I have to make sure that I'm trying to deliver the best care. But I'm doing this in a resource scarce environment, right? So how can I ensure that I'm optimally delivering care in this resource scarce environment? AI tools can help in improving those efficiencies and reducing waste and so on. So I think we should really try to understand AIs and educate ourselves about AI. And that starts from elementary school so that, the kids of today can really, plan for their future jobs where AI will be integral to their jobs.
Thank you for this rich conversation. I'm reminded of Ursula Franklin, who said, when things are not clear, it's good to start with language and clarify language. And picking up on your comment on the word AI and it being used to cover so many things, I'm coming from a lens of someone who works with a lot of graduate students who use AI for a wide range of things. And I realize the word doesn't mean the same thing to many people. And I'm concerned about the huge impact of AI on democratic trust, because in the lack of access to the human beings for care, people are turning to Gen AI for answers. They're fueled by fear. They're fueled by desire to get a speedy response. But the biggest voices in Gen AI are commercially driven. The more money to make, the more noise on the internet, the more the algorithms will point people in that direction. So I'm wondering if there's language we can develop and encourage in students to differentiate along, say, a spectrum of expertise. Sorry, I know I'm kind of rambling, but it's a complex thing I'm trying to say. I'm not worried about the experts who are prioritizing transplant care because I trust their expertise, and in the hands of experts, AI is powerful. I'm worried about the grade 5 student who starts to get a science lesson and has AI do the lesson because he's afraid he'll get a lower mark. So he never really learns the science. And I'm more concerned about the people who are nervous about a symptom and think they might have cancer and use Gen AI to look it up. And the AI separates information from expertise. And so they're not differentiating between what the Mayo Clinic lists for them and what an algorithm lists for them. And as you were saying, Professor Snyder, the algorithms keep us where we want to be, hover over what we're inclined to know. So I wonder if I could ask you to speak about ways that we can help open the discussion about the potential impact of AI on trust in science, trust in medicine. We need more language, more recognition of the vulnerability of those who are afraid, who are more likely to use AI and get misled by it, versus those who are more expert and can use the power of AI to help us all. So I hope in that comment there's a question.
Okay, I'm going to use an N of 1 just to tell a little story of how AI and commercial medicine can interact. So when I had sepsis and almost died, one of the things that happened was that I had a liver infection. In fact, that was like in this whole series of terrible things that could have killed me. This was probably the stupidest. They were all very stupid, but this was particularly stupid. So I'd had appendicitis and peritonitis and a whole lot of other things. And I went into sepsis, and as often happens with sepsis, it's not diagnosed right away. But the reason I went into sepsis was that I had a liver infection. That's where the infection was. And the ironic thing, or the funny thing, is that when I had my appendix out, the liver infection was noticed, or it wasn't noticed as an infection, but a spot or something was noticed on my liver, thanks to the wonders of technology, thanks to AI precisely, where, I mean, because you can do a bazillion samples, you get better at looking for certain kinds of patterns. And lo and behold, they found the pattern. Okay. But I was inside an appendicitis protocol, which demanded in the American hospital where I was that I be out of the hospital within X number of hours. So, boom, 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 I was gone out of the hospital, fine. And no one ever told me about the liver infection at all. And so I walked out of the hospital, went off on a family vacation, and meanwhile the infection was growing from my liver and led to sepsis, which is what almost killed me. So, like, when the AI did its job, right? Like the technology did its job, but what didn't do its job was the overall setting, which was one of commercial medicine, in which, as in many other such situations in the U.S., like the key is to keep people out of the hospital as quickly as possible, right? And so I was inside a protocol, which was essentially a commercial protocol, and as a result, I almost died. So the technical fix was there. It wasn't the machine's fault, but I was inside an overall commercial setting, and that's what almost killed me. And I set up that anecdote, which, don't worry, I can tell in like much more sordid detail. Like, that's a really like innocent version of all the idiocy that was involved in this. But the point is, the point I'm trying to make, the underlying point is that when we get into the AI discussion, it's very important to also have a capitalism discussion, because from the point of view of a practitioner, one can be confident that the models that one is using are safe and they're trustworthy. But if we get to a situation, which I think we're very close to, where you have a general sense that this stuff is wildly untrustworthy, that's going to create problems in the patient-physician interaction. But more specifically, like if you're Canada, or if you're the medical profession and you're thinking about AI going forward, I do think you have to worry, you have to at least be alert to and make sure you're talking about the possibility that this could be a vector by which profit making enters your system. And if we act innocent about that possibility, we're not going to be reassuring people. I'm not saying that's an inevitability, right? I'm not saying that it's something that we all have to be paranoid about. But as you say, the big generative AI stuff is all wildly for profit. And so it's reasonable to be concerned that so long as we're using the term AI, we talk about the capitalism problem. We don't want AI to be a way that commercial medicine enters into your system. That's reasonable. But then you're fundamentally right. Like, one of the reasons that this conversation is difficult is that we're talking about essentially quite different technologies all at the same time. And one of the reasons we're doing that is because of the wild profitability of certain kinds of these technologies.
Thank you. Because of our time, we can only take one more question and then we will wrap it up.
Again, may I go?
Yeah.
Thank you. Thank you so much for very informative discussion. My question for Professor Snyder, I'm a forensic psychiatrist, and one of my mentors once reflected on medicine historically, from historical perspective. First, medicine was viewed as a magic, then witchcraft, then art, then science, but now it's a business. Whether it's business for capitalism or whether it's business for for more democratic societies. I had experience to live in different regimes, political regimes, different countries. And just from your understanding, from your expertise historically, what do you think would be the big threat for medicine, given, and specifically from Canadian context, given all the changing political powers in the world, from more democratic political powers to more totalitarian, where we know historically medicine is a tool. And again, I'm coming from maybe forensic psychiatric perspective, where in certain regimes, medicine can be used as a tool. Is there something that, as an academic society, we can be mindful of or do to really prepare ourselves, or help society with these threats. And maybe my question from positions of fear that we talked about, but thank you very much in advance.
Okay, so the question is, asking a historian of totalitarianism how healthcare can go wrong. Rather than taking that one straight up, I have something to say, but I just actually wanted to ask colleagues to say a word about your question, because I think they are in some ways much better positioned to answer. I have something to say, but I think maybe we could just do this as a closing round and then wrap up.
Yeah, look, what I'll share on this one is that when you're seeing a physician, when you're seeing a health professional, their responsibility is to you, is to the person in front of them. And obviously, we can't be naive to the idea that there could be potential for corporate influence, profit influence, and et cetera, depending on where they're practicing, what their community of practice looks like, who's influencing those health professionals. But at the core of healthcare is that one-on-one or small room interaction between human being and human being, with one human being having the responsibility of acting in the best interest of the person that's receiving the care. And I think that's enormously protective of influence in the best possible way, and something to protect and cherish, especially as we get into this world of more and more AI being incorporated into medicine, more and more commercial interests in healthcare, and that personal encounter is so important to sustain despite all of that.
Okay, I guess it's just me. Yeah, so I'm going to start with. I want to start with. So the thing that I'm most concerned about in the present setting, I already articulated, which is keeping the body on one side of the commodification line. That's what I'm most concerned about. That in the U.S. it's on the other side. It's on the other. The body is essentially a commodity. And there are lots of great doctors and lots of wonderful nurses and lots of terrific researchers, but essentially the body's on the wrong side of the commodification line. And people who are much brighter than me about this have, including terrific medical researchers, have said similar things in public. And that's a fundamental line that once you get across it, it's very hard to get back the other direction. And so from the Canadian point of view, that's just one way of thinking about it, keeping the body on the right side of the commodification line. And echoing these remarks a little bit, the body can be used negatively in politics, but it can also be used positively. And I mean, I thought it was very striking way back in the beginning when Carney and others were reacting to the first round of Trump threats, that one of the things that Canadian politicians said, trying to distinguish themselves from the U.S., was that we have access to health care. And I think there's actually a fundamental insight there, because having access to health care isn't the same as having access to, a certain kind of consumer good. It's something which goes much deeper. And it's not just like a branding difference between Canada and the U.S. It's an actual difference. It changes the way you live your lives. And so the positive way of thinking about that, as colleagues have already articulated, is that the frailties to which we are subject are opportunities for humans, with the help of technique, to do good things for other humans, and thereby not just address illness in the narrow medical sense, but also create a sense more broadly that we are capable of helping each other, right? And that, of course, is very important for democracy. And so, there's specific things on the U.S. side that are going wrong. Like there are ways that we're now playing with eugenics, which are quite terrifying. There are ways in which RFK Jr. and that cohort are trying to expand, let's call it wellness, at the expense of health, in order to create new zones of profitability for hucksters. That's a bad thing which is happening. There are specific things that are happening, but the most important thing, I think, is to start with this notion that the body shouldn't be commodified, because once it's commodified, that's not only bad for healthcare and bad for life expectancy, it's also bad for the overall, as we say for a reason, body politic, because a democratic body politic is based on the notion that we can help each other in critical circumstances. And when you lose that idea, then you start to lose the idea that you are demos. You start to lose the idea that we actually belong together in some basic way. So I think it's really important in these discussions. This is so annoying to be an American, like given the last word in Canada. Like it's like, I'm still feeling bad about how the hockey turned out, honestly. No, I am. I feel bad in both cases. Like especially yeah, right. I do feel. I mean, I feel a little bit sorry for the behavior of some of our players, honestly. But okay, let's not go down that. So, I was working towards something grand here. But it's that, like, you can see how easily it tips one way or the other, and it can, and by way of like apparently innocent rhetorics of efficiency and resources and so on, and you can open little holes that allow the body to be commodified, and then before you know it, like the finger's out of the dike and the thing bursts, and that's what I worry about. So there are many other terrible things that can happen with respect to the body, and when one looks at history. But this is the thing that I think is most pertinent: is Canadians seeing this as something positive, deeply positive. That the way you deal with the body here is constitutive not just of your difference with the U.S., but of your democracy as a whole, and that is something that can be made better, and that your democracy will get better if you make it better.
I just want to say a huge thank you to our panelists.
panelists.
A round of applause for them again. Thank you. We're grateful to you for sharing your expertise and your insights here with us. Thank you. And thank you, everyone, for coming out too. And I hope you had a good time at this event. And enjoy the rest of your day.